sleepiness is to talk or do some action. So there was a request from one of my young friends that we should talk about sagittal balance. So how many people know anything about sagittal balance reasonably well? Oh, you have an expert, then I won't talk. Sagittal balance is very important topic because the first thing that happens is once you finish your basic fixation 1, 2, 3 levels, then you start realizing there's little more to it than just learning the actual technique. So let me start with what happened. Can you connect me there? Oh, it's there? Okay. So this is, okay. Are you guys able to hear? So this is not an advanced course on sagittal balance. This is a basic understanding. How many are neurosurgeons? How many orthopedic surgeons? Oh, sorry, I should have asked. Who is the neurosurgeons here first? Okay, majority. So the orthopedic surgeons also, if the remaining ones, put some mind to it. Let me explain by saying that it's a long way to learn about sagittal balance. There are a lot of controversies straight away. Some people agree with what I say. Some people necessarily may not agree with what I say, but it doesn't matter. Understanding basic principles is the key. So what is sagittal balance? We'll have some definitions first. So to understand this is important. This is the femoral heads in a lateral X-ray. Typically the two heads should be overlapping each other. In many X-rays the femoral heads may not be overlapping each other. There is a way of, suppose the femoral head is like this, then you connect the center of which, take the 50%, that becomes the center of the femoral heads, practical in an X-ray. Then you draw a line of the sacrum at the S1. The center of which joins the center of this is the line which is very important to remember. Okay, I'll tell you again, 50% of the top surface of the sacrum, you mark a point, join it to the center of the femoral head, is this sacral femoral line. Then if you draw from this line perpendicular 90 degrees, one line, okay, that is the sacral angle. So the difference between, or the angle that incidents between this sacral line and the sacral femoral line is the pelvic incidence, called the PI. Pelvic incidence, the angle subtended by a line drawn between the center of the femoral heads and the sacral end plate, and a line drawn perpendicular to the sacral end plate. Will you remember this point? PI. Pelvic incidence is not going to change in your lifelong. Whatever surgery you do, pelvic incidence is a permanent thing when you are born with. That's something I want you to understand. PI cannot change. Normally it's around 50 degrees, easy to remember, give or take 5 degrees. But there are many situations depending on the obliquity of the person's pelvis and the way it is shaped, from 30 to 90 degrees. Easy to remember, no? 30 to 90. These are all round numbers I am making. So if you remember as 50, 5 are done minus PI. So remember that. Any questions on PI? It gets a little more complicated as we go. Then what is sacral slope? This is the horizontal line to the ground when you are standing, and the line that is subtended by the top portion of the sacral end plate, and the horizontal is called the sacral slope. So for purposes of understanding, if this angles more, the sacral slope angle increases, right? If it is a more vertical pelvis, sacral slope angle decreases. And remember that this is the point. You forget this point. Just remember the sacral slope in your mind. Pelvic tilt. Pelvic tilt is the angle formed by the vertical line, femoral heads, and the vertical plumb line. That's normally 10 degrees. Some varies 5, 10, 50, up to 30, depending on the way the pelvic bones are formed. This is very important to understand because you'll go crazy as you go higher. I'm teaching only simple things. How as a surgeon you should plan your surgery for these patients. Lumbar lordosis is the angle between the superior end plate of L1 and the S1. I'll show some picture. Normally it is about 50 degrees again. Typically lumbar lordosis and pelvic incidence have a plus minus 9 to 10 degrees. That's why number is similar. What did I tell you of the PI? 50 degrees, right? Pelvic incidence is 50 degrees. This is 40 to 60. So plus minus 9 or plus minus 10. Just remember these numbers. Now forget the slip angle. You forget the slip angle. And May readings, grade 1, 0, 2, all that. So let's come back to this picture again. Pelvic incidence is fixed from your age, whatever region. It will not change. Pelvic tilt is this. Sacral slope is that. Lumbar lordosis is L1, upper part, and S1, this. You draw perpendicular to that, the subtendon angle. So what is lumbar lordosis normally? 40 to 60. What is pelvic incidence? Usually 50 degrees plus minus 5. Just remember these simple numbers. For me to understand this took a while because I had to glean from several places, and whenever you read these high funda papers, there is a million variables given and you start scratching. Just remember the simple things. The idea is, how do you put it into practice? So if you see the C7 plumb line, sagittal vertical axis, SVA. This is sagittal vertical axis definition. Normally the center of C7, if you draw a line, it should fall at this point. What is that point? Posterior superior point of the sacrum, if you are standing erect, SVA. If it falls forward, it is called positive, it is called negative. Normally up to 5 to 6 mm is okay. Beyond that, it is not considered okay. 5 millimeters. Can you remember that point? Is it very difficult? Am I making it complicated? Very simple, no? In elderly, this is an elderly patient's X-ray. Elderly patients, you think I'm elderly? I'm not elderly. I'm still young as Vikas Naik. Elderly patients, if you see, what happens is, because of the rigidity that comes on and the reduction of flexibility, they tend to bend forward. Can you imagine this? Because the center of gravity falls forward, they flex their hip. So that's why elderly people walk like this. Now, ideally speaking, if they have a degenerative disc, if you want to make them straight and lordosis, and they become straight. So what is wrong if it is like this? Then the eye position goes down. So they lift their head up. Are you able to understand this? Normal, bend forward, flex this, head comes down, correct? To lift this. And this is very tiring for the spine muscles. Are you able to understand? You get neck pain. Elderly patients who are walking like this with neck pain, first thing people do is see some degeneration spine, say we'll operate. Please don't operate such patients. The neck pain is due to posture. You understand? So you have to understand some physiology, then it's easy. So far, have you understood? Any questions on this? No questions. Good. Am I doing okay, sir? So, the sagittal balance is all about maintaining center of gravity, I told you. If the center of gravity falls forward, knee flexes, hip flexes, and head erect. If it is something like this, then it is even worse. So, sagittal spinopelvic alignment is a combination of balance between spinal position parameters. Okay? So, you forget all this. This is what is important. Lumbar lordosis is PI plus or minus 9 degrees. If you remember this simple equation, at the way you do surgery, you should stop thinking. Okay? So, what is this algorithm got to do with our sagittal balance and surgery? So, this is, Professor, something which you like. I'm talking about sagittal balance, basics. So, you are an expert, but I thought I'll teach them some basic balance. And you can add value how it is. Can I continue? So, Mummaneni et al. Came up with a classification called MISDEF algorithm, minimally invasive spine, degenerative spine algorithm. Okay? So what they did was, they went as they balance. This is important to understand, sagittal balance. I told you this positive, neutral, this is negative. So if the C7 plumb line fell on this neutral, if it becomes positive more than SVA of 6 centimeter, okay, then pelvic tilt, I told you a pelvic tilt. How much was pelvic tilt normally? Not pelvic incidence. Pelvic tilt is 10 degrees to 15 degrees plus minus. If it is more than 25, then there will be a mismatch. I told you what is a mismatch? Lumbar pelvic incidence usually 10 degrees, right? If it is less than 10, if there is lateral, corner, they came up with this classification. When you should do MIS surgery, when you should do interbody fusion, when you should do osteotomies and corrective. It's a complicated thing. So this is what happens. I have made it simplistic for you, all this here. I have taken this example. So the pelvic incidence cannot change. A person has a fusion here. There is a curve. The lumbar lordosis is nice. Whereas in the same patient, another patient, this is more straighter. This is smaller than this or not? This is smaller. So this is angulating forward. So if you consider this fellow having this, the SVA will be forward. If the same person is having like this under normal kyphosis, the SVA tends to fall here. So if you get a good lumbar lordosis, in young patients, remember this, if you make an elderly patient straight like this, he will tolerate for a while and he will form what you call as junctional failures. They tried doing that. They looked at X-rays, they looked at MRIs, CT scans, did all the beautiful calculation. They had a perfect post-op X-ray, but had a failure at surgery. So how much do you correct then? Nobody in the world has an answer. So how do surgeons then go? I have a very middle of the road approach for all this. I correct 50%. So let's say SVA is here. I correct up to here. You can always argue with me and say, who told you this? It has worked for me. I have no data to share and say, okay, I'm the greatest guy on earth. I have 10,000 patients. No, I don't have. So this is how I have practiced, and my patient seems to be so far happy. There are an occasional patient who will complain of aches and pains, and we will show some examples. Are you clear so far? This is a very simple approach to sagittal balance. This is sagittal balance, not coronal balance. That's separate. This is sagittal. So this was the original class 1, 2, 3. Then they came with the degenerative spine algorithm for adult degenerative spinality. In some patients, what has happened, the spine had become rigid. Then how to make them come back? These are all remaining same, but they had a fused spine. If it is a fused spine, yes or no, then they would consider open surgery with osteotomies. This is addition. Can you remember this? MISDEF 1, MISDEF 2, there is addition of a rigid spine as a separate component, and try to see should you do osteotomies. So in my practice, this is only for me very rare. So if somebody wants to do glorious surgeries in institutes, this is very good. I generally not come across a situation where I'll do it. So in advanced economies, where patients at 70 will marry, will divorce, will have girlfriends or boyfriends, they want to be independent, they want to play golf, they want to do horse riding, they want to go on a yacht. This is very, very important. At least in the area where I practice in Bangalore, which is a reasonably advanced city in India, people don't go horse riding at 70, 75. Very few play golf at 80. And I'm not sure how many at 80 will have girlfriends or boyfriends. So it's nice to learn that there's something like this exists. As our society is changing, and we are changing gradually, please understand this. What we were 30 years ago and what we are now is a direct contradistinction to what I imagined I would be at that age. So this is the basic understanding of. Does this answer the question for you, sir? Okay. So let's work on a few cases. This is 74-year-old male. Remember, this man when I operated had very severe problems, multi-level. This is the MRI with stenosis, and you can see multi-level, and we have got a decent correction, decent correction. And I could correct more. How do I correct more? You know, what I do is I place the cage in front. If I compress this at all levels, okay, I can get another few degrees of, a couple of degrees here if I add, I'll get a lumbar curvature which is more. But I told you, instead of looking at like a pretty X-ray, I want to correct approximately 50. So if you consider this man's going up like that, the SVA will be somewhere here. Is that what my imagination? Okay? So 70 plus above, 75 above, be cautious. Another patient, this patient has coronal and sagittal imbalance. And we do this minimal access. All these cases are minimal access. This is minimal access. This is not open, please. This is all minimal access. So somebody asked me in the morning whether I can do 1, 2, 3, 4 level with this. You can. If you do it properly, it's possible. See, only thing is, I did the top off, I didn't add cage here. So there are 3 cages, and the curve is not bad. Another patient, curve is not bad. Again, old patients, remember, I can get additional curve, but I'm somewhat afraid of having. If you have any criticism, you can call me, ask me, sir. You ask me something? Yes. You had a doubt? This is in correct position. There was a coronal imbalance, it is appearing like that. This patient has coronal and sagittal imbalance, corrected. Again, partially. This patient was probably very old. This patient already has a hip replacement here. Okay? So, correcting minimal access, you can add one level top off, I do, especially if very old people. I try to avoid junctional levels. Nowadays, there is a doubt whether the sacrum can hold heavy metal all the way up. You can add sacral and as well as you can add iliac screws. So you can measure all these angles. The lumbar lord. So query for you. If the pelvic incidence is 50, what would be the lumbar lordosis, guys? 40 to 60. So if you keep that plus minus 9 degrees, 10 degrees for lumbar lordosis in your mind, when you are operating with a patient, how to control that mind is like that. So above 65, 70 years of age, don't do over correction or perfect correction. My suggestion is between 50-60% correction, they will be fine. Very old osteoporotic patients, you should be very smart in not doing perfect balance because they have a tendency to fail at the junctions. So be very cautious. Junctional kyphosis, junctional failures are very difficult. So you get a, this is OLIF of course, but you get, so you have 3 level OLIFs, 1 level TLIF and you get a good correction. So it is not impossible for a neurosurgeon to understand sagittal imbalance. Some basics I have taught you because somebody asked me. This is not a detailed lecture about analyzing all my patients which I have done over 10 years, what happened 5 years down the line. No. This is basic understanding. If you have questions, I am willing to answer.
In all such cases, all are 70 years old. So do you do DEXA before putting all these big procedures?
Yes, sir.
And what if DEXA is say -4?
So we have to make them better, no? Let's say -4, we give them teriparatide for 3 months, give them calcium, give them some physiotherapy, painkillers. So we have to manage them as it happens. I have had patients who takes a long time to recover. You put special screws, fenestrated screws, cements, put them. The idea is to make them mobilize for their life to get better. Idea is not to make them, I told you, ride horses. That's what I am thinking. I'm sorry, I can't hear. Yes. So remember, in patients with degenerative disc disease multi-level, anyway they don't have much movement. One of the things you must realize is, for most times, many people say in disc degeneration, natural endpoint is fusion. That's a very rare occurrence. Most times there is somehow a space. Nature tries to preserve the disc. It fuses, but rarely. Even if they have unless they have a dish or some other infection or some other disease, or like angst-pond or something. Most times the disc is tend to be preserved. Even though there is an narrow disc, you do a CT scan, you will see some vacuum phenomena. You put a spacer, a trial, it opens up. So you will always find. The answer to your question is, was there a movement earlier? No. In advanced degenerative disease where the facets are hypertrophied and the disc is degenerated, I don't think there is any movement.
So sometimes
the surgery is for pain and disability.
So, sometimes what I have seen is patients, they still complain of backache. Maybe their claudication symptoms have gone, but with this type of solid construct, they are not able to move.
Why do they get pain is because I keep telling you, you're not thinking about the balance. I want you to start, because we also did the same mistake in the late 2008, 2009, we are making long constructs. Patients will be fine for 1 or 2 years and then pain. Then we realized there is something more to it. And then the French masters came and gave us this talk about sagittal balance, which was not very commonly thought of in those days. We have slowly modified our thinking. How much can you maintain a lordosis in relation to the person's age? Unfortunately, there is no data to say at age 70 you should have this much lordosis. at age 80 you should have lordosis like that. There is no regional data. Americans may have, French may have. I don't know if Russia has data for that. Indians, we don't have data. Do you know what is the average age of survival of Indian male? 67. You know what is average age survival for Indian female? About 69. That is old data. New data may add a couple of years. Remember, every decade you add between 3 to 5 years if you are a healthy country or if there is no starvation, famine, disease, etc. So basically you are looking at assuming that in India today in 2024-25 average age of survival is 69-70 years. Anybody surviving beyond 70 is living on bonus time on average. I mean, I don't mean in a crude way. I'm just trying to understand the way how much survival they will have, 10 years, 20 years. How much functional can they be? How much pain-free can they be? This is what you should look at.
Sagittal imbalance because of degeneration, and degeneration is mostly not causing fusion of the disc. So this postural thing can be, most of the cases can be managed with the physiotherapy modalities or standing rather than non-surgical techniques.
Correct. Your answer is perfect. We don't operate all degenerative spines.
Yeah, so what are the specific indications?
Patients who have significant pain where the pain comes in their activities of daily living and which restricts their activities significantly. Suppose there is a lady, grand old ma in the house. She was a very active dancer when she was young. At 75, she is very happy sitting in the chair, no pain, watching TV. She has got a bent spine, she is not bothered. Don't operate her.
Sir.
No, you understand. On the other hand, I'll come to you, sir. On the other hand, the person wants to walk to the market half a kilometer, 1 kilometer. He's 65, 70, 75. Children are in America or Japan, someplace working. Every time he wants to go to the market, he has to, every 5 minutes he has to stop. Those are people who get functionally better by operation. So choose your patients very carefully. We are not here in a race to show our prowess as surgeons. We are here to show that if we do something, is it going to benefit them? If you do limited surgery in them, I have seen people do just decompressive laminectomies. They get worse even fast. They'll curse the surgeon. So we have done all those experiments. It doesn't work. Sagittal balance is something to be understood. And if that balance is understood in a way that it makes a meaningful difference to the outcome of your patients, please learn this. That's what I'm trying to tell. It doesn't apply to all patients. You will see out of 100 patients who come who are 70 plus above in your OPD, believe me, in India, you will not end up operating more than 10-20%.
All the spine surgeon in their career see patients which even after beautiful surgeries, the patient is still suffering from pain. I would like to add a point here, that most of these patients, they have conditioning of the subconscious mind due to pain. That's why the pain persists. You see post-op X-ray, MRI, they are beautiful, but still the pain is persisting. There is a big role of subconscious mind which modern spine surgeon have overlooked. There are hidden emotions in the subconscious mind which maintains the pain, and we never address the subconscious mind.
I have only a comment to do that. That's why you should be very cautious in operating patients. I have made this very clear. Learning spine surgery technique is one aspect. How to use, when to use them in any patient is an art. There's a lot of science to it, but an art. If you find there is a doubt that the patient may not benefit from surgery or is going to have a limited benefit, please don't operate. The first chance, if the patient says, do you think I'm going to get worse or I may not benefit, I have to think about it, doctor, please say, please think. 5 months, 8 months, 10 months, don't come back. And I'm not saying just on the stage. People who have worked with me know about this. The first thing is, unless there is a life-threatening disease for somebody, any functional surgery which improves function, reduces pain, the family and the patient himself or herself should be very clear on what the risks are and what the outcomes will be. Operations of a spine surgery is not a panacea for all evils in the spine. Remember that. There are more to it than we understand, and you are right.
Sir, do we need to screen the cervical spine if they have a significant,
I
before
showed you,
fixing?
whole spine X-ray.
Yes, sir, for all.
In our practice, all patients with any lumbar spine, cervical, whatever, get a whole spine evaluation. It is mandatory to do it nowadays. And we do standing X-rays. All X-rays on the lumbar spine has to be done, AP and lateral flexion extension in standing. You should load the spine. And I can give a number of examples, any one of you have seen. I had seen a patient who came from England who had 5 MRIs. In NHS, getting 5 MRIs is not a joke, because each time they go, they get postponed 5-6 months. 5 MRIs, lumbar pain, significant. All we did was get standing X-rays. And at a grade 2 list this L5S1, which was missed. We have missed. I'm giving this example not because NHS is a terrible system. No. Please, their systems many times are far better than the systems we have. But even a well-processed system, well-wishing surgeon in their busy OPD schedules can miss a small thing. So in your OPDs, somebody comes for you and says, sir, I have back pain, this is the MRI. Before you look at the MRI, ask for what happened to the X-rays. If you don't have X-rays, or the patient says, I got X-ray done 2 years ago and I have not brought it, you say, I will not give an opinion. You get the X-rays done again. So if you start thinking in your mind to go on a process-driven scale, X-rays, standing, MRIs, then of course correlate this independently with what the patient has, and try to be conservative in your thought process, not aggressive, you'll do all right.
So thank you, sir. Thank you so much for beautifully explaining the geometry of the spine and getting us with all the angles right. So thank you very much. And I would like to invite the next talk. We can take more questions for the deformity with Professor Sergey Kolesov. Professor Sergey? Dr. Pankaj? Just call it. You are on. So Professor Sergey Kolesov is from Russia. He is president of Russian Federation of Spine, and he's currently working in Moscow. His special interests are deformity corrections. So he will be giving us a brief overview on the deformities. So Professor Sergey, please.
Dear colleagues, thank you very much for invitation for this cadaver course. I'm Kolesov. I'm spine surgeonist. I'm working in Moscow. I am Chief of Spine Surgery Department in Central Institute of Traumatology and Orthopedics. I will show you a new system we create for dynamic correction of the scoliosis. We call it spine flexes, and the system produced by KOMISS company. This company takes place in Moscow. We know that dynamic correction of the scoliosis deformity is not very spread using in the world, and on the market we have tether system. It's Zimmer company produced begin from 2019. Globus company producing for tethering dynamic system, and now Medtronic company start work and at Brave, a system for tethering. All the system using only from children and VBT technology, only for modulation, growth modulation of the spine. We create a Russian system, we call it spine flexes, which consists from screws, set screws, staple, and cord. This system, it's possible use not only from children and from adult population too. This is technology preparing of the cord. It's very complicated technology, and cord should be very resistant to dynamic loading because the most spread complication from the VBT is damage of the cord and losing correction. Our system indication for use, sclerosis deformity of thoracic, thoracolumbar, lumbar regions, deformity up to 70 to 80 degree, high mobility index should be. We can use it like tethering for modulation of the bone growth. And of course, we can use it from adult patients for complete correction, very mobile deformity in thoracic, thoracolumbar, and lumbar spine. Absence of degenerative changes of invertebral disc need, absence of osteoporotic or osteopenia, and less than 40 degree of thoracic kyphosis. It's contraindication for dynamic correction. Surgical technique, there are two basic techniques. It's tethering, when we're introducing one screw to the vertebral body, one cord, and according to the spine growth, we can see correction of the sclerotic deformity. From adult, we use another technique. We're introducing two screws in the vertebral body. We use two cords, and we use disc release, partial nucleotomy, each level which we include in fixation. And in this case, loading on the cord less than tethering technology. And we can do complete correction, mobile deformity in thoracic, thoracolumbar, and lumbar spine. We use, in some cases, endoscopic technique and mini thoracophrenotomy. Nucleotomy should be used in ISC. We call this technique ISC, anterior sclerosis correction technique. Each level which we're introducing screws in vertebral body. We should preservation the end plates. In some cases possible make resection rib heads for increased mobility, especially in thoracic region. I should be careful do mobilization sympathetic chain, and all cases we're using staples for increase stability vertebral screw in the body. Usually we are stretching cord from cranial towards the caudal, but in some cases it can be changed from caudal to cranial. It's possible simultaneous tension of two cords. The tension is carried out visually under control of fluoroscopy. And in adult patients, we do maximum tension as possible. This technique from adult, more aggressive intervention compared with children. As I said, put two screws into the vertebral body using tension of both cords. We can do derotation of the vertebral bodies with use special screw holders and make contraction body. When we do contraction of the body, it gives spontaneous vertebral body derotation. We tested this cord on the special machine, and for breakage it's need near 300 kilograms loading. And we check it on the cyclic loading, and our cord can do more than 10 million cycles without any damage. And in some cases, we can, on the power machine, deformity of the head of the screws and no breakage of this cord. KOMISS company producing this system, and now we using for last 3 years, and more than 400 patients was operated with quite good results. About results, I will tell you tomorrow. This is technique stretching the pedicle screws into vertebral body on the 3D model of the spine. In the up part of the, especially thoracic spine, possible use only one screws because vertebral body too small, and two screws it's dangerous use because vertebral body can destroy it. We're using some single-using instruments for tension cord, special ports, special tube for tensioning cord, and special devices for introducing screws in right position in thoracic and thoracolumbar spine with using 3D technology, single-use and individual implants. And we create special protectors for the rib, for thoracotomy, for prophylaxis of the injured and fractured ribs through thoracotomy. I can show you some cases. This patient with thoracic scoliosis, we use this our system like technology, endoscopic approach. It's approach cutting vessels on the vertebral body, segmental vessels, and introducing screws with staples into spine, and introducing cord through special device, inserting them to screws, and make tension with special device. And X-ray after surgery is mini-invasive thoracoscopic technique, and after 2-3 months after surgery, patient, he is professional dancer, can dance without any problem, without any pain. And I some cases show you patient 15 years old, Reser near 4. The growing of the spine is finished. She using corsets for treating scoliosis and deformity before surgery, and we use ISC technology to screws segmental partial nucleotomy of the apex of the deformity, and make finally correction with complete correction from 45 to 0 degree. And we tested movement in the spine after surgery, and movement and function of muscles very close to completely healthy patients. 17 years old patients with thoracic curvature near 45 degree mobile. We're using a spine flexi system from her, and with complete correction of the spine. And 41 years old patients with near 90 degree deformity, mobile. We have operated her 2 years ago, and 90 degree we decreased to 28 degree with good cosmesis and functional results. And 2 years after surgery, the level of correction is stable. 17 years old boy, 72 degree, mobile deformity, of course, and using system with partial nucleotomy, introducing 2 screws, 2 cords, and with very good correction after surgery. In conclusion, I can say that this new system was created. The test results of strength and corrector are satisfactory. Complication association with elements of the system in immediately at least 2 years follow-up after surgery was very good. And now we're doing large prospective studies for learning the system in our population, patient, from adult and from children. Thank you very much. Maybe because all system producing in US very high price, our system at least 2 times cheaper, and maybe for Indian population it will be good. Thank you.
Thank you very much, sir, for a very nice lecture. Any questions? Yeah.
I have a question for you, Professor. Now, when you're choosing the levels for fusion, do you use the same calculation that we use for posterior approach to know the upper level of fusion and the lower level of fusion? Or is there a, because you're doing anterior and direct correction, is there a different calculation that you are using?
This is technology. I suppose it's we have 4 different systems. First generation is distractors, like Alan, for example. Second generation is Harrington. Third generation is Cottrell-Debussy system for 3D dimensional correction. And now I think this system is fourth generation because we do, it's no fusion technology. The main idea of this technology, using elastic cord, nucleotomy each level. When we do nucleotomy, we decrease movement in the vertebral segments. That's why decrease level of power on the cord. And this cord can survive in more than, I suppose, at least 5, maybe 7 years, maybe more. Because now we have follow-up 5 years, the most follow-up period. Maybe, I think follow-up will be more. And this technology give patients chance to give movement. And we give permission completely sports, walking, bending after 6 weeks after surgery, 6 weeks. And the level of complication really very low, especially lumbar, pneumonia, hemothorax, and device, problem with device, screws, cords, we haven't seen in this technology. But in VBT technology, the breakage of the cord quite high, near 50%, because using only one cord and don't touch disc segment, working like health, and the cord is after in middle 2 years damage. In this technology, we haven't seen it. But of course, we should estimate follow-up period, but at least 5 years is good.
So what is the material of this cord?
It's Lavsan, maybe you know. It's polymer.
Yeah, thank you very much, Professor. Thank you very much. We have a round of applause for Professor. Tomorrow he is again demonstrating a beautiful surgery in the world. Yeah. So we come to the end of this session, MCQ plus Professor's lectures, and I mean there was a bonus, like we could get Rajkumar's lecture on sagittal balance. So we are in positive balance. So now we have Dr. Hitesh, Dr. Shashwat, Dr. Pankaj Singh, Professor Rajendra sir with us, Dr. Rajakumar is there, Professor Sergey is there, and then Dr. Siddharth, Satya, Paresh, Dr. Sarang, Dr. Rakshit, Dr. Samir Futane, Dr. Mayur Kurdile, and Dr. Raghav. So these people will be manning, this faculty will be manning 8 stations, their name are displayed there. Rest of the delegates, we combine both the groups. Those who have been divided, one in A group and B group, please join in that respective one group, and then this faculty are there for interaction and demonstrating if at all you have any queries on the Sorbonne model. So we break from here, we go to Sorbonne model station just near that corridor, you all know by now, and let's have that final session of the day. And after that, I mean you met the buses will fly out from 5:30 here, 5:36. It will take you to swimming pool, which is into main AIIMS campus, where we'll unwind after this so busy day with the poolside dinner, right? Thank you.